Welcome to our second and last video on bullous skin diseases. Let's begin. In this lecture, we'll discuss dermatitis herpetiformis and gestational pemphigoid. Let's start with the definition. Dermatitis herpetiformis is an autoimmune blistering disease that commonly occurs in association with celiac disease, also known as gluten-sensitive enteropathy. In this lecture, we will only focus on the skin manifestations of this condition. Note that male predominance is characteristic of this skin condition. Now let's take a minute to understand the pathophysiology behind this disease. Dermatitis herpetiformis results from an immune response to the dietary gluten, leading to IgA deposition in the papillary dermis. As a result, neutrophil recruitment and complement activation occur. You should know that genetics could be the primary triggering factor because both celiac disease and dermatitis herpetiformis are associated with the expression of the same HLA types, such as HLA-DQ2, DQ8, and HLA-DR3. Hence, if a patient has a genetic predisposition along with a diet high in gluten, their immune system may start the formation of IgA antibodies against gluten tissue transglutaminase in the gut, which then cross-react with the epidermal transglutaminase. This leads to the deposition of IgA and epidermal transglutaminase in the papillary dermis, resulting in dermatitis herpetiformis skin lesions with subepidermal vesicles and microabscesses due to neutrophil recruitment. Next, let's discuss possible risk factors for dermatitis herpetiformis. As we've already mentioned, dermatitis herpetiformis is a manifestation of gluten sensitivity, thus the major contributing risk factor is celiac disease. So foods such as barley, rye, and wheat, which contain a high amount of gliadin, should be eliminated from the diet in patients with celiac disease. Other associated risk factors include sun exposure, trauma, oral iodine administration, autoimmune thyroid disease, and type 1 diabetes. For the boards, you're expected to know the classical clinical presentation of patients with dermatitis herpetiformis. Before we jump to the clinical presentation, it's important to note that this skin condition was named herpetiformis only because it resembles the lesions seen in herpes. Otherwise, there is no connection between herpes virus and dermatitis herpetiformis. The patient typically reports burning blisters, intense itching, and the presence of grouped papules, plaques, and vesicles that are symmetrically distributed on the extensor surfaces, such as the elbows, knees, and buttocks. Here's an image showing papulovesicular eruptions with erythema and excoriations, suggestive of dermatitis herpetiformis. Now let's talk about the diagnostic approach. The initial step for making a diagnosis includes a thorough history and physical examination to detect characteristic skin lesions of dermatitis herpetiformis. After that, to confirm the diagnosis, a skin biopsy is done. Histology of the tested lesion reveals subepidermal vesicles along with papillary microabscesses. Direct immunofluorescence should be then performed. It's the gold standard used to diagnose this condition and typically shows granular IgA deposits in the tips of the dermal papillae. We've already mentioned the strong association between celiac disease and dermatitis herpetiformis. Hence, all patients with this skin condition should be evaluated for celiac disease via serologic tests. Detection of serologic markers such as endomysial antibodies, tissue transglutaminase antibodies, and epidermal transglutaminase antibodies will confirm the diagnosis of celiac disease. This image depicts the histopathologic appearance of dermatitis herpetiformis showing subepidermal vesicles and neutrophilic microabscesses. And finally, let's discuss the treatment. The primary goal for the treatment is to decrease the immune system stimulation from gluten, along with reducing neutrophil recruitment and function. Hence, there are two major treatment options for dermatitis herpetiformis, including a gluten-free diet and dapsone. Note that a gluten-free diet decreases gut mucosa-induced stimulation of the immune system, and dapsone decreases neutrophil recruitment and function. If dapsone is not well tolerated by the patients, other sulfa drugs such as sulfasalazine can be used. Overall, you should know that after the stabilization of the disease, which usually takes months to a year, patients can stop taking medications but have to remain on a strict gluten-free diet. A 24-year-old male comes to the physician due to pruritic skin lesions. He first noticed small blisters on his elbows and buttocks 7 months ago, but he did not pay much attention until the itching became unbearable. His past medical history is significant for steatorrhea, iron deficiency anemia, and osteomalacia. Physical exam shows grouped vesicles and papules on bilateral olecranon and buttocks. What is the most likely pathophysiology of his skin lesions? This is a young patient with pruritic vesicles and papules on the elbows and buttocks. He also has signs and symptoms of malabsorption, such as steatorrhea, iron deficiency anemia, and osteomalacia. A generalized malabsorption syndrome combined with a rash on extensor surfaces is consistent with celiac disease accompanied with dermatitis herpetiformis. Dermatitis herpetiformis is caused by IgA deposition at the tips of dermal papillae, resulting in small vesicles on extensor surfaces. Finally, let's briefly discuss gestational pemphigoid. Let's define and understand the pathophysiology first. Gestational pemphigoid is a pregnancy-related bullous disease. It is thought to be idiopathic or autoimmune, resulting in subepidermal blister eruption in the second and third trimesters. It is a variant of bullous pemphigoid that essentially only affects pregnant women. The pathophysiology, therefore, is similar to that of bullous pemphigoid, which eventually leads to subepidermal blisters. Pregnant women with gestational pemphigoid typically report having intensely pruritic plaques and papules that usually start around the umbilicus. After delivery, symptoms resolve within 3 months, but recurrence with menses or OCP intake can happen. Note that this autoimmune skin condition can be worse during the next pregnancies. In terms of diagnosis, the characteristic clinical presentation should be detected on physical exam. After that, it's important to do a skin biopsy and identify the appropriate histopathology, which usually shows subepidermal blisters. Direct immunofluorescence can be performed, which will reveal linear C3 and IgG deposition over the basement membrane. Note that direct immunofluorescence is the differentiating test between gestational pemphigoid and pruritic urticarial papules of pregnancy, which typically have negative immunofluorescence. Finally, the primary goal of the treatment is to reduce the symptoms and prevent new skin blister formation in a pregnant woman. For all affected patients, conservative treatment with emollients and baths is recommended, and usually blisters heal after delivery, as the condition is often self-limiting. If a pregnant woman has a mild gestational pemphigoid, antihistamines and topical steroids such as triamcinolone are used for the management. In severe cases, an oral steroid can be trialed. Here's a table that summarizes some of the important features of autoimmune blistering skin conditions discussed in the lecture and the previous lecture. Take a moment to pause the video and review the key information we have covered in this lecture. A 28-year-old woman comes to the physician reporting itchy rash for the past month. She first noticed the rash on her knees, but similar lesions have appeared on her buttocks as well. Her past medical history is significant for refractory iron deficiency anemia. Her vital signs are unremarkable. Laboratory findings are significant for hemoglobin 8, prothrombin time of 20 seconds, partial thromboplastin time of 50 seconds, and alkaline phosphatase of 150. Physical exam reveals pruritic grouped vesicles and papules on the knees and buttocks. Which of the following is the best treatment option for this patient's skin condition? A. Rifampin, B. Ciprofloxacin, C. Aztreonam, D. Dapsone. This young woman presents with itchy rash for the past month. Physical exam reveals pruritic grouped vesicles and papules on the knees and buttocks. Her past medical history is significant for refractory iron deficiency anemia. Laboratory findings are significant for hemoglobin of 8, which reflects the anemia. Prothrombin time is 20 seconds, which is prolonged. The partial thromboplastin time is 50 seconds, which is also prolonged. Prolonged PT and PTT may indicate a vitamin K deficiency due to malabsorption. Alkaline phosphatase is increased to 150, reflecting osteoblastic hyperactivity due to possible osteomalacia. All these findings are consistent with the diagnosis of celiac disease and dermatitis herpetiformis. The best treatment option for dermatitis herpetiformis is Dapsone. So the correct answer is option D. Here's a slide reminding us of the management of dermatitis herpetiformis. Let's discuss now why other options are incorrect. Option A, rifampin, option B, ciprofloxacin, and option C, aztreonam, are not used in the management of dermatitis herpetiformis. And that concludes our lecture on dermatitis herpetiformis and gestational pemphigoid.